All right, so we're just going to jump right into it. We're going to talk about the other section of hematology and really anemia. So I've been spending a lot of time diving into this and really trying to understand it. And the one thing I never really realized, and the thing you have to, if somebody's diagnosed with iron deficiency anemia, you don't just have that. Like, it's not like a genetic thing. You're not just, oh, I have iron deficient anemia. And obviously, there are genetic causes and things and inflammatory responses to anemia. But you get iron deficiency anemia because you're bleeding. And acute blood loss is normally normocytic anemia in terms of your MCV. But iron deficient anemia, which is a little bit more chronic, let's say you have like peptic ulcer disease or you have some kind of like insidious GI bleed or something, it's going to take a little bit longer. So chronic blood loss is going to be more microcytic. And we'll talk about why in a second. But when you lose blood, there's iron bound to hemoglobin. And I actually just Googled this. The body recycles like 90% of the iron that's in hemoglobin. So you're losing the capacity to recycle. Obviously you're bleeding out blood that has iron in it as well. But then, yeah, the body doesn't have, the iron stores because it's not able to recycle. So that's why you get iron deficient anemia. You can't just have that as a diagnosis. You're not done. Where are they losing? You have to figure out, well, where are they losing blood from? Where is this coming from? So anyway, maybe that's a little bit more simple to grasp than me, but it kind of took me a while to realize like, yeah, they have this, but why? But anyway, so this is what an iron panel looks like. I actually copy and pasted this, like the text right from Epic. So iron, ferritin, iron saturation, TIBC, folate, B12. So let's kind of just talk about what these are. Where's the iron panel? Here. So the first thing we talk about here is ferritin. Ferritin is just iron stores. So iron is stored as ferritin in the liver. Despite that, we can check a serum level to check the body's total body iron stores. Ferritin is going to go down before any other marker in terms of an anemia. Makes sense. We're going to use up our stores. It's notable that ferritin is also an acute phase reactant, so it's increased during inflammation, malignancy, or infection, which makes sense because the body is under stress. So likely we need some extra perfusion and we probably need some more blood. So we're going to mobilize our stores. We're going to push ferritin into the blood so that the body can utilize it. So it makes sense. So total iron binding capacity, and these are pictures I had never seen in P1 year, but I think this is really interesting. So from what I understand, so this is a hepatocyte. So total iron binding capacity, we kind of have to talk about transferrin. So transferrin is simply a carrier protein for iron, like albumin is to calcium. Transferrin is produced in the liver, and you can see these are transferrin molecules, the triangle over here and the little circle here, and there's two binding sites for iron. So transferrin is what is binding iron, and the total iron binding capacity simply means it's a synonymous with transferrin. Same thing. And they're kind of confusing. Transferrin is a molecule, binding capacity is like a measure, but it's the trucks that are on the road. Transferrin is a truck. It can hold iron. How many iron can it hold? Two. So total iron binding capacity is simply measuring how many trucks are on the road. Hypothetically, not how much iron is in the trucks, but hypothetically, how much iron could we actually carry with transferrin? And that's exactly what this looks like here. It's like, okay, if we have, whether we have iron or not, can we mobilize it? That's important. That's why TIBC is an important measure. So that is transferrin. Those are the same exact thing. Now, transferrin saturation, which is, from what I understand, the same thing as iron saturation, the same thing as just percent saturation, the same thing as saturation. These are all synonyms. This is, okay, this is their transferrin. Are they actually carrying iron? Are they saturated or are they not saturated? And then serum iron really isn't important. That's just like how much free iron is in the blood. And we actually can't measure that very easily, which is why we right? But I guess we do measure it. It's just not very accurate. Like ferritin is going to be the thing that you measure. All right, the other thing, this isn't on an iron panel, but these are all the things, if you understand the difference, like you'll get all the questions right because it's like, here's the iron panel, whatever, they're anemic, hemoglobin's low, but the RDW is this. So what is it? All right, so what the heck is RDW? So RDW is the red blood cell distribution width, and it simply measures like the standard deviation, the variation of your red blood cells. Are they all the same size? Are they varying sizes, or is there some variation? And I think what's important is a normal RDW, there's some variation in your blood cells in the size. They're not all exactly the same size, because if you had a low RDW, that would mean there is no variation and all of your red blood cells are the exact same size. And really, for the purposes of this, low and normal are kind of the same thing. It's differentiating between low or normal and high. A high RDW means you have some small red blood cells, some normal red blood cells, and some large red blood cells. And you could see that in this picture here. So this would be an increased RDW, and this would be a normal RDW, which is either, all the same size or just like a minor variation. Okay. So with all that said, with RDW, the big thing is with something like iron deficiency anemia. You have some iron, you're losing blood, but you're not losing all of your blood. So as you're recycling your blood cells, as you're creating new ones, you're able to give some of them iron, some of them are normal size, maybe even a little bit larger than that, but you don't have enough iron. So some of the cells end up being pretty small. So you have a high RDW. You have a big distribution in your sizes. But when you have something like thalassemia, whether it's alpha or beta, that's a chromosomal defect. Every single cell is affected. Every single cell that has a nucleus that has chromosomes is affected. So your RDW is normal or probably low. Same thing with something like anemia of chronic disease. It's just generic inflammation throughout your entire body. It doesn't discriminate. Everybody's affected. So RDW there is going to be low as well, or low or normal. Okay, so I really wanted to finish this table, but it was taking me way too much time. It's a redo of, like, I had made this one initially, but it's missing some pieces. But we'll talk about this. We'll talk about what I have so far, because the big ones are really the ones I covered. So iron deficiency anemia, it's the number one cause of anemia in general. Number one cause is that chronic blood loss we talked about. Check the reproductive system first in women, and then the GI tract, and then check the GI tract first in men. Symptoms here, glossitis, that kind of like red inflamed tongue, koilonychia, which is like those spoon nails, and then pagophagia, which is like an affinity for eating ice, which is kind of weird. You also have this Plummer-Vinson syndrome, which you learn about in GI. So there's a triad here. It's iron deficient anemia itself, dysphagia, and then esophageal webs. So iron stores are low, which makes sense. Transferrin is unaffected. We still have trucks on the road. Hepatocytes are still manufacturing transferrin, but there's no iron to saturate them. So saturation is low. And like we just talked about, RDW is going to be high. All right. So find the bleed and give them some iron. And the way I have this table set up, and I think this is really important from like a spatial studying, is everything on the left is microcytic. You can see the MCV less than 80. Everything in the middle is normocytic, and everything on the right is macrocytic. And in fact, that spatial relationship helped me get some questions right on my OSCE, because I could just picture my table and it was a low MCV, and I just unloaded everything that was on the left side of the chart. So it's so helpful to organize stuff like this. So still with a microcytic anemia, we have sideroblastic. This is an issue with, so a porphyrin ring is, or porphyrin, whatever, it's the actual like architecture that goes into hemoglobin because you have like the four heme subunits, and then like in heme, it's an actual ring with iron bound to nitrogen. In this case, and this is a genetic issue, um, you're not able to make those rings. All right, so there's a defect in porphyrin rings. Now, even though it's genetic, you can make some rings, just some of them are a little wonky. So what does that mean in terms of RDW? It means it's high. So some of your red blood cells are okay. Some of the other ones, yeah, we really couldn't figure out the ring. We have this defect. We're really not, working with a full team here. So that's why your RDW is high here. And you have plenty of stores, but because you can't make these rings correctly, you just can't really use a lot of it. So that's why this is an anemia in general. And this is why ferritin here is going to be high when compared to iron deficiency anemia when ferritin is going to be low. Anemia chronic disease, this is, you have like rheumatoid arthritis, or you have like CKD can do this, Crohn's, TB, alcoholism. CKD, think about why, because, erythropoietin, EPO, is made in the kidneys. So if you have CKD, you're not going to be able to upregulate your red blood cells. And then just like, yeah, general inflammation is going to kind of use more blood, and you're going to kind of, use up those stores, and you're going to become anemic. So normal high ferritin, the normal low RDW, I think is the important thing here. Again, chronic inflammation does not discriminate. Everybody's going to be affected. When we talk about, where's thalassemia? Over here. Very proud of this graph. Am I still sharing correctly? Yeah. Okay. So this is thalassemia. These are chromosomal issues. Alpha thalassemia is an issue with two genes. All right. This is chromosome 16, two genes, and you multiply by two basically because there's like two alleles per gene here. So there's four possibilities. The one is you have an upset in one allele. Silent carrier, you're completely fine. Alpha thalassemia minor, you either have two on the same are knocked out, or one on both are knocked out. And yeah, still fine. You're going to start to see some target cells. Now is when it gets a little confusing. So alpha thalassemia means you aren't making alpha chains. And to make normal adult hemoglobin, you need two alpha chains and you need two beta chains. So if you're talking about alpha thalassemia, you're not able to make those alpha chains. You have a surplus of beta. And when you get to alpha thalassemia intermedia, this third step here, also called HBH disease, and it's called HBH disease because the name of the hemoglobin that's made of four beta units, whatever, which you can see here, is just called HBH. It just is. I don't know what the H stands for. Hemoglobin, beta hemoglobin. I don't know. So that's called HBH disease. You have no alpha chains. You have one allele that's kind of working, but it's messed up. You really can't make alpha. So you have this HBH disease. Symptomatic at birth. You could still live with this. But yeah, you have those four beta chains. Then you go on to the only thalassemia, I'm pretty sure, that is completely incompatible with life because you can't make any alpha at all. You really can't make any hemoglobin. And what happens here is that you can't even make HbF. Oh, yeah, you can't make fetal hemoglobin, which needs some alpha. So because all of your alleles are knocked out, you can't make fetal hemoglobin, which means you can't be born. This is incompatible with life. It's also called hemoglobin Bart's. I don't know why it's called that, or hydrops fetalis, or alpha thalassemia major. All the same thing, incompatible with life. The hemoglobin that your body creates are called gamma tetramers. These are unique to alpha thalassemia. They use gamma. So knowing that this is for beta and then this is gamma is important for alpha. The big thing that's always asked is, you have a patient that presents and they're anemic. Are they iron deficient or do they have beta thalassemia minor? Because they both present exactly the same way. The differentiator is in the RDW. Remember, iron deficiency anemia, high RDW, some small with a little bit of iron, some normal, some big with plenty of iron. Beta thalassemia, it's genetic. Everybody's affected. You're going to have a low or normal RDW. Okay. This one, it's really technically two because intermediate and major are both missing both alleles, but you can have like a more mild case, which is called beta thalassemia intermedia. And the names are confused because here minor and trait are the same thing. So, whatever. But if the boss fight of alpha is Bart's hydrops fatalis, the boss fight of beta is Cooley's anemia. So you can think of like you beta be cool, to know that those two go together. This, you have some really interesting physical findings. You have this crew cut appearance to your skull, and you have this chipmunk face. The crew cut appearance is that epocytes, the manufacture of cells in your bone, of red blood cells in your bones, increase. You have like this hypertrophy of your bones, which is why you get that. And then there's this weird med loose patercept, which I think is pretty new that you can use for that. Okay, that should be not all the microcytic anemia. Sickle cell's on there too. Yeah, I mean, I'm not going to go really into detail for that because I want to get into this other stuff. Get out. Okay, when we talk about the normocytic anemias, you have aplastic anemia. So this is a bone marrow failure. Number one cause is just idiopathic. It just happens. There's a bunch of meds that can do this. Pregnancy can do it. That's actually pretty interesting. Yeah, you get this Fanconi anemia. It's the most common congenital cause. It's autosomal recessive. So knowing Fanconi and aplastic are together. And here, because it's your bone marrow, you have pancytopenia, which, knocks out your blood cells. And it's kind of like you have HIV. So fungal mortality, you think about something like pneumocystis jirovecii, which, is opportunistic for HIV patients. So kind of the same thing here. Parvo, which is that slapped cheek fifth disease. I think I meant to say EBV here, probably. I don't know what EBC is. That's probably Epstein-Barr. G6PD, know your Heinz bodies, know your bite cells. You're taking a bite out of a hamburger with Heinz ketchup in it. Oxidative stress is going to cause this. This is recessive X-linked. And anything that stresses you, infection, a bunch of meds. Fava beans is the big one that always comes up on like smarty pants questions for whatever reason. I forget why. An increased retic count. A retic count is uh, are your red blood cell precursors. So if your bone marrow is fine, your retic count is going to go up. So that's normocytic. And then you have hereditary spherocytosis. Yeah, this has to do with those. Is this the anchoring proteins or is that something else? Pig A. No, it's not anchoring. That's going to be something else, which we'll talk about in a second. This is going to be oh, I thought this was hypochromic. This is hyperchromic because you have these like fat cells. This isn't macrocytic. They're not larger, but you know how red blood cells are usually like concave in the middle. They're not. They're like thick in the middle, which means if you think of like holding up a red blood cell, you can kind of see through it because it has that thin middle. But with hereditary spherocytosis, it's thicker in the middle, so it's more rich in color. So you have hyperchromia, literally an increase in color. Yeah, splenomegaly here. Yeah, here you can use this EMA binding test and osmotic fragility. Those are definitely things you want to keep associated with hereditary spherocytosis. Let's open this up. Yeah, no EMA binding test, osmotic fragility have to do with hereditary spherocytosis. No, it's hyperchromic. And what are the other words? Yeah, band 3, ankyrin, spectrin. These are defects in the red blood cell membrane, so it can't keep that concave shape. And there you have it. The other thing is paroxysmal nocturnal hemoglobinuria. This happens at like night. This has to do with this PIG-A gene. And yeah, this has to do with anchor proteins, which I think usually like keep complement away. So complement comes and actually starts hemolyzing this, which makes you anemia or anemic. But it like happens at night, I think, because like your body is, I forget why it's actually. Yeah, paroxysmal nocturnal hemoglobinuria is an acquired hemolytic anemia involving a mutation of the PIG-A gene. Oh, okay. And it leads to recurrent episodes of hemolysis that occurs at night. It's because our urine becomes more concentrated during sleep. That's that's crazy. The myeloid part. Yikes. Yowza. So yeah, these are the anchoring proteins that normally keep complement away. Complement comes and is like, hey, do you want me to destroy this? And it does. You can use something called flow cytometry, and you can use these antibodies. So make sure you get vaccinated. So I guess this is kind of like functional asplenia. Is that a thing? Yeah, kind of, or at least you're immunocompromised because complement is going crazy. All right, so that again is normocytic. Then, of course, we get into these two. So folate versus B12. So you want to know folate is in vegetables. So if you're a vegetarian, you're going to have a B12 deficiency. However, B12 takes 5 to 10 years to exhaust, and folate takes only 4 weeks. I think it's definitely important to know that, you'll learn that like methotrexate and folic acid go hand in hand. You know, um, methotrexate can be like an abortive, and folic acid is a like a prenatal vitamin. So keep those two with each other. And then metformin can cause a B12 deficiency. So there's these two M medications, but keep methotrexate and folate together. Folate is absorbed in the jejunum. Isn't B12 like terminal ileum? Yeah. Okay, let's go. And I always think I still use this to this day, but I think of the mnemonic don't just ingest. So duodenum, jejunum, ileum. Literally every time I think about the small intestine, I have to go through that, and it's always worked for me. So the big thing here with folate versus B12 is B12 gets neurologic symptoms because B12 is used to, I think it's used to manufacture myelin. I'm pretty sure. So you're going to get ataxia, loss of vibration sense, numbness, tingling, anything that hints towards neurologic, it's going to be B12. Because all the other stuff, atrophic glossitis, angular colitis around the mouth, other stuff like that are shared with like all anemia, basically. You can get neuro stuff with folate, but if you see it in a vignette, if you see it on like a pants question, it's gonna be B12. And then yeah, these are like megaloblastic. But the other thing too is it's not just neuropathy, but it's yeah, it's neuropsychiatric changes. It's personality. So it can be something really, really subtle in the vignette. So just look out for it. And then just like the EMA and osmotic went with hereditary spherocytosis, right? Yep. The Schilling test, man, I would never have remembered that. The Schilling test is what you use for B12. I think that's like, oh yeah, I always get these questions wrong. That's always been very confusing for me. The other big thing is that you have homocysteine and you have um, methyl malonic acid. In folate, B9, it's a smaller number. You only see elevated homocysteine. In B12 deficiency, you're going to see elevations of both, of homocysteine and methyl malonic acid. The other thing with, and again, these are macrocytic anemias, so folate and B12 deficiency. And those are megaloblastic. You can also have a non-megaloblastic anemia. Number one cause is going to be alcoholism. I think that's the big one. Hypothyroidism. I forgot you can get anemia with that. But yeah, any type of liver issue is going to be a non-megaloblastic, but still, to be honest, I don't remember what megaloblastic means. Oh, I guess it has to do with the precursors. Whatever. But yeah, just knowing just knowing your MCVs and what's micro, normal, macrocytic gets you down like 50-50 for like most of these questions. And then you just have to look at other differentiators like RDW again is a big one and symptoms and things like that. I feel like that's kind of it. I'll do one more and we'll talk about these other like more hemonkish things and maybe we'll touch a little bit on some of the cancers. But for now, we'll take a little break. All right, so let's just do a quick review of all of hemonc, I guess. Oh, down here. So yeah, lymphoma, leukemia, multiple myeloma, dysplasia. Tumor marker, I will never learn the tumor markers. I have tried. They do not stick to memory. I don't even remember which ones we need to know anymore. I don't know. At some point, I will commit those to memory, but that day is not today. I think that's pretty much it. All right. So yeah, here's oncology. All right. So the way I have this set up is you have leukemias are on the left. You have acute leukemia, you have chronic leukemia, and then you have lymphoma on the right. So keep simpler at the top for Hodgkin lymphoma. Non-Hodgkin lymphoma is at the bottom. So what are the big picture buzzword questions that we should know for this? So you start with AML. So we have how do I have this done? So yeah, okay, so it's acute and it's chronic. I kind of wish I did this a slightly different way. All the acutes are on the left, and then you start with myeloid, and then you go to lymphocytic. That's, all right, so acute myeloid leukemia is the first one. We talk about what are the big things here. Our rods are going to be the big buzzword here. So AML, our rods, and then you have all these different letters. So M3 is going to be the big one that you get with You can get DIC with vitamin A um, is the treatment, which is a good thing. M4, M5, you get these gingival CNS manifestations. So this is all in the upper left, and you're going to see this in adults. Now, if we go down to acute lymphocytic leukemia, this is going to be more, not only more common in kids, but 80% of childhood leukemias. You can get it in an adult, but most of the time, this is going to be a kid. And then there's two cancers here that have to do with the Philadelphia chromosome. It's ALL and then the exact opposite, CML. So chronic myelocytic and then acute lymphocytic. However, this one is, it can involve the Philadelphia chromosome. And when it does here, that's a bad thing. The one that's more common is CML, and that's actually a good thing. So CML is all about the Philadelphia chromosome. When ALL comes in, CML is like, what's going on? Philadelphia chromosome is my thing. ALL is like, whoops, I took this, and this is actually a really bad prognosis. So there you go. Resistance to walking, that's a big thing, I think, that you could potentially see in a vignette, because this is going to be a kid who's maybe over the what, like 1 year threshold of walking. CNS involvement, testicular enlargement, that's going to be another thing. And then, yeah, I think knowing like the tyrosine kinase inhibitors, Gleevec, tumor lysis syndrome is a risk factor for a lot of these. Hyperkalemia, phosphatemia, because your cells are bursting, I think. All right. So moving on to CML. So this is the Philadelphia chromosome one. You're going to see smudge and basket cells. However, you see that for all lymphocytic. I'm sorry, you see that for all chronic leukemias. You see smudge cells because you see them down here as well. Same thing in terms of the ALL with these tyrosine kinase inhibitors. And then CLL is going to be the most common type of leukemia in the Western world. So the L's, you think of, if it's acute, it's an acute issue, it's going to be a kid. Chronic, it's going to be, this is the most common. This is mean age 65, 70. So older people, it's chronic and incurable. You get this chromatin clumping, which is this snickerdoodle-like appearance. And then you can have this Richter's transformation where CLL develops into high-grade non-Hodgkin's lymphoma. So CLL actually hops to the right of this chart and becomes NHL. Oh, that's really interesting. So acute is on the left, and then we have chronic, and then it's the L's are at the bottom, and then the M's are at the top. Okay. All right. I feel like there's a lot of really high value stuff here with lymphoma. Epstein-Barr virus being a risk factor for Hodgkin lymphoma is like so important. I feel like that comes up all the time. Reed-Sternberg cells. So Reed-Sternberg cells are going to be Hodgkin's lymphoma. Our rods are going to be, is it AML? Okay, so our rods are AML, smudge basket are in the center. And then is there a weird type of cell down here? I don't think so. Okay, so Epstein-Barr and then Pell-Ebstein fevers. So just put the Epstein and Epstein together. The alcohol-induced pain, that is super unique. So with minutes of ingestion, you get pain at the sites of a bony involvement, or you get like lymphadenopathy. So highly specific for Hodgkin lymphoma. That's pretty interesting. Brentuximab, so this is where you have Adcetris, the Ann Arbor staging system. This is important. So you have one lymph node that's enlarged, stage one, easy. Stage two, okay, more than one lymph node, but on the same side of the diaphragm. So I have one here, and maybe I have like a supraclavicular one. And it can be over here, right? It can cross midline. but I don't have one in like my inguinal area or something. Um, or somewhere in my abdomen, like whatever. Stage two or stage three is okay. Now we have this on both sides of the diaphragm. So maybe somewhere in my pelvis and then somewhere up here would be stage three. And then stage four is extranodal organs or tissues. So I don't know, you have it in your brain or your prostate or something. Like it's not a lymph node anymore. It's actually in an organ. In types of Hodgkin lymphoma, nodular sclerosing, like you're nodding yes, is going to be the most common type. Again, you're going to see those Reed-Sternberg cells. Non-Hodgkin lymphoma spreads not. So yeah, they always say Hodgkin stays at home. So I guess it doesn't go to the organs as often, but this one does. Spreads non-contiguously, and B symptoms are less common. B symptoms, what, like fever, chills, weight loss? I'm pretty sure. This you use rituximab. All right. And then there's this is like super high yield stuff. There's 6 types of non-Hodgkin lymphoma. So this is where things get uh, crazy. So you have high grade and you have like low grade. So most common NHL in general is diffuse large B cell. The diffuse large B cell most popular. Adult T cell. There's Burkitt's lymphoma. That's where you have this is like a pretty unique one. Starry sky appearance, more common in children. This is where you get like face, like an enlarged face and jaw. Epstein-Barr is here also. Hairy cell, you get a dry tap. That comes up twice. Myelofibrosis. Jeez. Okay. And then was it hairy cell? So dry tap for hairy cell, fried egg appearance. I do not miss this at all. I don't know. That's the high yield stuff. Hopefully that's enough for like an internal medicine question. It's probably just going to be really big picture things. Let's see what else is important here. Yeah, so I don't know what myelodysplastic syndrome is. Couldn't tell you one thing about this. So this is okay. So this is in the elderly, abnormal myeloid cells. You have pancytopenia. Yeah, these are the pseudo Pelger-Hewitt cells, dumbbell-shaped nuclei. So that's myelodysplastic. Stem cell transplant. That's really all I care about at this point. I think knowing it's a disease of the elderly is important, and then dumbbell-shaped nuclei, myelodysplastic syndrome. Moving on. All right, polycythemia vera. So this is going to be all your JAK2 stuff. So essential thrombocytosis. And then do you get this with this too? Yeah, primary myelofibrosis. Didn't even know that was totally forgot that was a thing. Took this exam just a couple months ago. All right, polycythemia vera. So it's just an increase in red blood cells. So it can be relative, primary, or secondary. So yeah, secondary is like a physiologic response. So EPO is going to be high. If it's primary, there's probably like something wrong with the kidneys itself. Oh no, okay, I'm sorry. So primarily your red blood cells are increased. EPO is like, okay, take the wheel. We don't need to do anything. We're going to go to sleep. Here, it's something that's causing EPO, like a paraneoplastic syndrome or something. So primary EPO goes to sleep. That's, I think, really important. So we have JAK2, erythromelalgia. What is that? Pain from red blood cells? Oh, yeah, just burning pain in the extremities. Okay. Yeah, this is all primary spilling into this area. You can get some gout stuff. You can get amaurosis fugax. What is like? You can get like little like yeah, little like micro infarcts and stuff maybe. I can't believe I had this all memorized at one point. It's just unreal looking back. You treat it with aspirin, but that doesn't impact red cell mass. Therapeutic phlebotomy will do that. Jeez, man. Essential thrombocytosis, JAK2 gene again. Chiari syndrome. Most benign of all myeloproliferative disease, life expectancy is near normal. JAK2, yeah. Then you have this calreticulin gene, female predominance, bleeding because excess platelets will consume and deplete von Willebrand factor. What is this? It's just high platelets and you consume von Willebrand. So it's almost like a DIC, like platelets, or you have too many, they're used up, and then you actually start bleeding. Aspirin, hydroxyurea, intermediate risk. Yeah. All right, then we have teardrop cells or dacrocytes. That's going to be primary myelofibrosis, another JAK2 mutation, and another dry tap. Okay, sure. All right, let's just do. This is insane. I can't. I'm blown away at how much information we had to know. All right, so multiple. I'm just going to read all this. Multiple myeloma. Multiple myeloma is the most common plasma cell disorder by a long shot. A single plasma B cell line proliferates, meaning a single immunoglobulin is overproduced. Higher incidence here in those over 50 and more common in Black men. Multiple myeloma is no joke here with a median survival of 3 years. That's crazy. Rheumatoid arthritis is a notable risk factor. The immunoglobulins usually affected here are either IgG or IgA, and that defines the heavy chain. This causes tubular obstruction, which impairs renal function. A big characteristic factor here are lytic lesions. Myeloma cells produce osteoclastic activating factors. So osteoclastic are the ones that pull um, the calcium phosphate from the bone that up that upregulate our recycling osteoclasts and inhibit, and they all, okay, so it's a double effect, and inhibit our builder osteoblasts, leading to the destruction of bone. Bone marrow is suppressed, so we get anemia and thrombocytopenia. Okay, so we can't manufacture blood cells. But also, since one immunoglobulin is being favored, the others are suppressed, so there's an increased risk of infection. Look for low back pain on a vignette. 70% of multiple myeloma patients will have some type of bone pain. And if osteoclasts are going ham, we get hypercalcemia without an elevated alk phos, which would point to a hepatic cause. All right, so just look for normal LFTs. The most common physical finding, however, is simply due to that anemia and is pallor. Okay, never would have remembered that. The excess plasma cells can cause plasmacytomas, which cause neurologic compression, so look for peripheral neuropathy. Then we have the crabs of multiple myeloma. So it's calcium elevation. So we talked about why. Renal insufficiency, because it wreaks havoc on your kidneys. Anemia, obviously, and then bone lesions. That's easy enough to remember. The above symptoms will also present with end organ damage. Okay, so look for like AKIs. Labs will show normochromic, normocytic anemia, and a rouleau formation, which is a stack of coins, diagnosed with electrophoresis. And this is where you get that charged M protein called the M spike. So it's IgG, IgA, and an M spike, an M protein, also called the church spire. IgG generally is the most common, so 50%. You also get these Bence-Jones proteins. Just, this should be a color. It's a buzzword city over here. Treatment. Bisphosphonates are another option to decrease hypercalcemia, bone pain. Okay. Let's look at, let's read, let's read a little about hypercalcemia. Okay. 90% of all cases of hypercalcemia are linked to either hyperparathyroidism or malignancy. So the parathyroid hormone, I always think like parachutes calcium out of the bone. PTH. Now, this I thought was really interesting. When PTH is upregulated and it upregulates osteoclasts, because you need more calcium and you need to get it from your bone. You can't just pull a calcium ion from the bone. It's bonded with calcium phosphate. And what happens is it brings the calcium into your blood, it brings the phosphate into your blood, but the phosphorus is actually excreted through the urine. So when you look at PTH, it increases calcium but decreases phosphorus. When you look at vitamin D, which works on, I mean, all this stuff works on the bones, the intestines, and the kidneys, but vitamin D increases them both. It increases calcium and it increases phosphorus. So just like an important thing to know. All right, hypercalcemia of malignancy is the most common metabolic emergency of malignancy and the most common paraneoplastic syndrome. I would not have remembered that. That's crazy. Never would I have thought of that. I probably would have said like tumor lysis syndrome. Uh, Path here is increased bone resorption. And remember, resorption is it's not absorption, it's resorption is pulling from bone to the blood with three mechanisms: osteolytic metastases, tumor secretion. Then you get kidney stones because you have all this calcium floating around, bone pain because your bones are literally being eaten, nausea because reasons, psychiatric overtones because reasons. Um, Oh, and I added this. So stones, bones, abdominal groans, psychiatric overtones, and pantalones. So you have brisk diuresis to look for polyuria. That's so funny. So look for like hypovolemia. I like how I'm saying whatever. Ionized calcium, blah, blah, blah. You have hypophosphatemia. There we go. So I just explained why. And then you get QT shortening. That's the interesting thing. We talk so much about QT prolongation. Um, with like Zofran and macrolides and a bunch of other stuff and hypocalcemia, right? But hypercalcemia is going to be QT shortening. And the reason this happens is when you think about a muscle contraction with like the sarcoplasmic reticulum and all that stuff, like calcium ions are what are going to trigger a muscle contraction. So when we're hypocalcemic, it's pretty easy. It just kind of slows things down. So it prolongs the QT. But the problem is when we don't have enough calcium, the muscles are like, well, we can either not contract at all and you'll die because your heart won't beat, or we can lower our threshold at the like voltage gated channels, stay open a little bit longer. You don't have as much calcium, so we need to stay open a little bit longer to actually contract the muscle to actually get the heart to beat. But the problem is when you lower the threshold like that, you have a high chance of overexcitability. If there's a sudden influx, and you've lowered your threshold for a contraction, you can, contract too much or too fast. And that's why with hypocalcemia, you get stuff like Schwazdeck sign, you get Trousseau sign, you get tetany, you get muscle spasms because they've lowered their standards. They've lowered their threshold for what's acceptable for a muscle contraction. And the problem with that also is it's prolonging your QT. All the channels are open longer. You have a chance for not only overexcitability with like your visible muscles, but with your heart. And that's why hypocalcemia and prolonged QT can cause torsades, can cause really bad um, cardiac rhythms. I mean, hypercalcemia probably not great for your heart either, right? But really, in the symptoms, there's nothing cardiac here. So That's pretty interesting, right? Um, you'd think, you know, because you'd think an extreme in both ends, but hypocalcemia more for sure. But yeah, QT shortening here, and then Osborne J waves, which the only other place I've heard of those is with hypothermia. Calcitonin. Yeah, I think just fluids are the most important thing here. All right. So let's talk about tumor lysis syndrome and call it a day. All right, so tumor lysis syndrome, where cell lysis results in a massive release of intracellular ions, namely potassium and phosphate. DNA also leaks out and is broken down, causing hyperuricemia. That's really interesting. So your high grade NHLs like Burkitt's. Burkitt's was the one with it's like was that like jaw stuff? Epstein-Barr jaw stuff. Burkitt's. And that's an NHL. Yeah, jaw stuff, Epstein-Barr, starry sky, diffuse large, most common. Hairy cell, dry tap, threads, fried egg. Okay, so acute tumor lysis syndrome, where cell lysis results in a massive release of intracellular ions, namely potassium and phosphate. Well, I already read all this. So you get hyperuricemia because of DNA, hyperkalemia because potassium from the cells. I guess I mean, there's phosphate in our cell membranes, right? That's like it's like a biphosphate layer. That's probably where that's coming from. Hypocalcemia. Why do you get hypocalcemia? Oh, increased phosphorus binds to existing calcium, causing calcium phosphate precipitate. That's pretty cool. Okay. Wow, that's really interesting. Symptoms, yeah, sudden death. Is that really a symptom? Yeah, and then when we expand to hypocalcemia territory, we bring back Schwarzschild sign, Trousseau sign, twitching, brachiordia. Yeah, okay. So hypocalcemia, that's a big one. Hyperkalemia, of course, will lead to peak T waves and then sine waves, and then eventually a widened QRS. Yeah, there you go, sine waves. Hyperuricemia can lead to acute renal failure. Mainstay of treatment is prevention. But how do you get this? Like, why does this happen? Cancer cells break down rapidly. Yeah, but why? Not because we're attacking them, right? Oh, it is from treatment. That's what I thought. So this is iatrogenic, really. I don't know that I ever put that together, if I'm being honest with you. That's that's how fast P1 year goes. Like, yeah, this is like the drinking from the fire hose thing of like you grab just as much as you can. You just know it's word association. Hey, I know this word and this is the stuff that goes with it. Do I fully understand it? Absolutely not, because there's no time. There's no time to fully understand things. Look at this document. This is one exam. Look at all the words in just this one table. And there's like 10 of these. Prevention, namely with IV hydration prior to and during chemotherapy. Yeah, it's like break out the old hyperkalemia triple threat. Oh yeah, very important. See a big K. Calcium, albuterol, bicarb, insulin, glucose. That's not even in order. So albuterol is all about the beta 2 agonist property, which interferes with the sodium potassium channels to relax bronchial smooth muscles. Bicarb makes the blood basic, so the body tries to correct this, turns on the hydrogen potassium pump, which is in the stomach, I believe, hauls in protons and kicks out potassium from the blood. In terms of insulin, it appears that the stimulation of glycogen, yeah, I Googled all this. Glycogen creating cells need a lot of intracellular water, so they suck in water and potassium inward, reducing serum potassium using that same channel. For unstable EKG, you want to use calcium gluconate. So when you start to see probably peak T waves and symptomatic, but definitely sine waves, or like a widened QRS, then to actually secrete out, yeah, you need to use Kxalate or what's the other one? Lokelma. I've seen that before in the hospital. Actually, I think they use that instead of Kxalate because I think it works faster. Because this is actually going to withdraw potassium into the blood. I don't know if it's PO or oral, but or PO or IV, whatever. For hyperuricemia, use allopurinol as antioxidase inhibitor. Hyperphosphatemia, use antacids, calcium to bind up. Yeah, that's interesting. To bind up even more of the phosphorus. So you get to the phosphorus before it can get to all your calcium, or you're just repleting your calcium. Yeah, correct that first. Okay, I'm satisfied. I don't even know what I'm going to do next. I should probably look at cardiology. Maybe GI or something. All right, see you in the next one.